Hi, I'm Justin Lee, radiologist. I work at Fortius and Princess Grace and in London. I'm just going to be talking to you about imaging of pelvis, groin and hip pain. This may work, you never know. So when we're being asked to look at groin pain as radiologists, we have to think about the so-called pain generators, which are, we can sort of subdivide them into articular causes, bone, tendon, and muscular causes. So when I'm looking at imaging for these cases, they're the sort of things that will be running through my mind. So I'm just going to run through those. Hopefully won't take up too much of your time. But the first one, and probably most common, is articular causes of hip pain. So we're going to talk a little bit about femoral acetabular impingement, and then a little bit about osteochondral injuries. We probably won't talk about hip ligament tears. I'm sure lots of you already know this, but FAI is a descriptive diagnosis, and it's really about clinical signs, symptoms, and pathology. It's not all about our imaging. In fact, our imaging will, as I'm sure you know, frequently overstate the presence of hip impingement in asymptomatic individuals. So we have to be mindful of that when we're reporting our scans and x-rays for you guys. So it's a mechanical entity where you have an abutment of proximal femur with the acetabular rim. As you may know, there are three described types, certainly in the radiological literature. There's the Cam type, the pincer type, which formerly was known, the artist formerly known as coxa profunda, and then the mixed type. And in our sphere, there's a lot of work done in the mid-2000s from Zurich, which suggested the mixed type was the most common, but I've got a feeling really that actually the Cam type is the most common. So why do we need to image it if it's a clinical diagnosis? Well, first of all, we need to look at the predisposing factors, and that's really about x-ray findings. Then if we're going to do more advanced imaging, it nearly always will end up being MRI in the first instance. So there are various ways of looking at it on MRI. You can either do an arthrogram or not arthrogram. So this stands for direct MR arthrography. And we'll talk a little bit about that. We don't do much indirect MRI arthrography anymore, mainly because it requires intravenous contrast. So we're not doing so much of that. CT and 3D recons really follows on after the MRI in most cases. So current practice, we start with a plain film and then usually typically move on to a plain MRI. I have to say, as the 3T scanners are increasing in prevalence across the country, we're doing less and less arthrography. In the Birmingham hip unit, they're hardly doing any arthrograms. So I think that's been a reflection of my own practice. So let's see how we go. So for contralabral damage, we're looking for labral tears to cartilage. You can still get very good imaging at 1.5 Tesla, which I'm sure is what you'll be getting from most of your centers. And what we're looking for is the presence of high signal cutting between the labrum and the bone, whether it be intravenous, intra-articular contrast, or whether it be just simple joint fluid, depends on your technique. But essentially, you're looking for some fluid undercutting the labrum against the bone or the contralabral junction. And in this case, you can see a little cyst and then a little fissure in the cartilage. So you can get it all from the MR arthrogram. You can't ever have a hip impingement lecture without some form of explosion. And this is the typical appearance where the Americans just simply call it a bump lesion. And you have the flattening of the femoral head neck junction hitting against the labrum, causing a little explosion. It's called a cam on the basis of the camshaft of an engine. And here is a surgical correlatory image with the flattening of that head neck junction. We describe a Cam Triad on imaging, which is that you have abnormal head neck morphology, labral tear, and cartilage abnormality. If you have all three, you can be at least in some way confident that they may have a hip impingement. We recognize two types of Cam lesion on imaging. So the first type is the classic pistol grip deformity on X-ray. I'm going to talk about the alpha angle in just a second, but essentially you're looking for loss of the normal sphericity, which is a funny word, but it basically means it's not as round as it should be. The alpha angle is a little bit controversial. They're sort of arbitrary. Considered normal is 62 on X-ray, 55 on CT MRI. This OS refers to the offset. The offset gets much narrower in cases of Cam morphology. You can measure this on the lateral, you can measure it on the AEP, but I have to say, as time's gone on, either the clinical graphics is doing it for you, or you guys aren't so interested. But anyway, it's there, that's the alpha angle, that's a normal, and that's an abnormal, because the head-neck junction is not here where it should be, it's up here because of the cam lesion. So you elevate the angle being between the center of the femoral head in a line along the femoral neck, and then to the periphery, head-neck junction, where the head stops being spherical. This is it on CT. I mean, this is a bilateral cam lesion on CT. I'm not saying that this is the way that one would diagnose it, but often for clinical graphics, which is a computer-aided design motion analysis technique, you will see these sort of images. So do you need an arthrogram or not? Well, the truth is that the arthrogram, even at 3T, is said to be more sensitive and accurate than an MRI without arthrogram. But patients don't like arthrograms, so if you can avoid it, then you probably should, particularly in younger patients. They don't like the procedure. 1 in 5 patients get an ache in the joint for a couple of days afterwards, and then there's a risk of radiation because you're invariably using X-ray, and finally the risk of introduced infection. So more and more I'm doing less and less, as they say. You see a paralabral cyst, similarly to elsewhere in the body, including the shoulder, you've almost certainly got a labral tear. So saying that, we obviously still do perform quite a high number of them, and this would be a typical picture. There are various access techniques. I know a lot of you will be doing your own arthrograms anyway. Just out of interest, if you go to this patient has an arthritis already, of course, but if you have a fairly benign looking hip, if you go into the superior femoral head neck junction, that technically is the highest accuracy rate for less leak of contrast and less painful, again, according to radiological imaging. So this would be a typical sort of appearance. You've got a large cam lesion. This is almost certainly a footballer, and you can see a tear through the labrum in this position. Okay, so we'll just run through that. And these are just a couple of further examples. You can see the contrast here just cutting right the way through the labral bone interface and then going into that paralabral sulcus, and then this is the associated cam lesion. What's interesting for me is that you often see a tear in the superlateral position and the cam lesion in the anterior position. It just shows, because of the rotational element, it's not quite straightforward. So the artist formerly known as coxa profunda, which is now known as pincer type morphology, is simple overcoverage. There is the general form of profunda and protrusio, and then there's the focal form of acetabular retroversion. So the pincer X-ray signs are really interesting because I think a lot of us radiologists don't really truly appreciate them. I'm sure it's not true for you surgeons, but there's this nice paper from HAR, I think in 2014, I think, just went through a review of the anatomy, which I think was really nice. But essentially there are a couple of things to point out to you. One of them is this line here, which is the ilio-ischial line. So it just runs down similar to the iliobacterial line, but instead heading south into the ilio-ischial line. That's a constant line. You'll always see it. And then you see the acetabular fovea. Now, the normal relationship is that the fovea is always lateral to the ilio-ischial line. If that relationship changes, then you've got a pincer deformity, and I'll show you that in the next couple of slides. So this is, again, just the offset over here. These are the various angles that get measured. This is AW stands for anterior wall. So this is a normal hip. The anterior wall always being medial to the posterior wall, which is this line here. This is the head fovea. These are a couple of angles, and this measurement here is the acetabular index, which some of you will call the tonus angle, and then this angle is the lateral center edge angle. And these are the two angles that I will regularly measure on my plane films, which is the lateral center edge and the acetabular index. So we'll just go through that on the profundus, and now what we're seeing is that the fovea is medial to the ilio-ischial line. That's it. That in itself is a really important sign to look for. What's interesting for me is if you have a dysplastic hip, that relationship is not constant. So you'll have a dysplastic hip with an elevated AI, and then the fovea is again medial to the ilio-ischial line. So this rule only applies if the hip is not dysplastic. So let's say this hip is not dysplastic because of the lateral, because of the acetabular index. So just to bear that in mind. And protrusio, I was always taught as a radiologist that protrusio was when the head is medial to the iliopectineal line, and that is actually incorrect. It's if the head is medial to the ilioischial line. It doesn't have to be all the way into the pelvis. Obviously, it comes in degrees, but if you have the head medial to the ilioischial line, it's acetabular protrusio. If you have the fovea only, then it's a coxa profunda. Both of them are pincer deformities. And this just goes back to what I was saying about focal pincer, which is the acetabular retroversion, where the anterior wall, as in this case, is now lateral to the posterior wall in the superior half. So this is known as the figure of 8 sign. So you can see this is the anterior wall, which should always be medial to the posterior wall. But at this point, in the superior third in this case, you can see that there is anterior is lateral to posterior. So now you have a figure of 8 sign. So you'll come across that term, figure of 8. And this is the last one to talk about, which is the deep posterior wall sign, which I think for some of the early work from Mr. Vida et al. Was suggesting this is a very important radiographic feature to look for. And it's where the posterior wall is lateral to the center of the femoral head. So you draw 2 lines, find the center of the head. Some of your PAC systems will be able to do that for you very easily, and you simply look at the posterior wall, and that's an important sign to look for. So this is a pincer deformity. This is clearly an acetabular protrusio, almost to the point where it looks like I've distorted the image to make the point, but I didn't. These are the original images. So we're going to run on just a little bit about osseous causes of bone stress injuries. I deal with a lot of athletes in my practice. I'm fortunate to have that group. And stress injuries are easily the most common bone pathology I see in my group. They're very common around the pelvis and hip. So we often use the Frederickson classification. That's from 1995, and that's been still in common use today. So we'll constantly be giving grading, but the reality is that when you look at the prognosis, the only thing that matters really is if there's a grade 4 injury, which is just a fancy way of saying fracture. So once you see a fracture line, the recovery rate goes through the roof compared to grade 1, 2, 3. But ideally, you want to get these injuries in grade 1 or grade 2 before it gets to grade 4. Just a little bit on demographics. It's much more common in women, presumably because of their bone density, and most of them are in the proximal femur rather than in the pelvis. This is important because most of our patients will have a negative X-ray diagnosis, and only half of them will be abnormal follow-up. So you just bear that in mind. If you get a normal X-ray, it doesn't exclude the diagnosis. So MRI we describe as gold standard. It is more specific than bone scintigraphy. The reality is that I think in today's society we're not really performing bone scintigraphy for bone stress injuries apart from in the setting of a SPECT CT scan. So this is an example where the X-ray is normal. The MRI shows a clear fracture of the femoral neck. Even at follow-up, you can just about make out a faint line, but it's a leap of faith. Just a couple of other examples. This is the fairly common location, which is the inferior pubic ramus. Just to bear in mind that when they have the inferior pubic ramus, just have a sneaky look at their sacrum, because the sacral fractures are often missed. Okay, so the next thing is just talk about transient bone marrow edema. Again, it says here young males following sports injury, but it's way more common in middle-aged females. So usually resolves spontaneously. Sometimes the rheumatologists will get involved. And this is a typical sort of picture, diffusely bright hip. This is a fluid-sensitive sequence. This is bone marrow edema throughout. They often get loss of synovitis and an effusion within the joint. And then we're going to move on to tendon courses. I mean, we could do a whole lecture on this, which I'm not going to, be pleased to know. Essentially, in the adolescent group, we get lots of apophyseal injuries, and in the adult group, we'll get lots of enthesopathies and tendinopathies. But there's a little bit of crossover between tendon, bone, and enthesis. So let's not get too carried away with that terminology and stress. The reality is that this is the issue. This is the young athlete. All of these parts of their body get ripped off because they're not mature enough to cope with the loads put upon it. So there's a little anterior inferior iliac spine. That's a rec fem injury. That's a very common injury in adolescent footballers. This is the anterior superior spine, which is for sartorius. and TFL, and then the anterior abdominal wall, but an ACIS is quite common. AIS is actually more common. This is a mature skeleton, almost 20 years old, and not much to see there. We're going to zoom that up, and then we'll move on, because if you just go onto the MRI now, he's actually pulled off the whole of that left adductor longus tendon, and this is it torn off. This is actually a bony avulsion here. Very hard to see, almost impossible to see, in fact, on the X-ray. So just to finish off just a little bit, we're going to cover a little bit of muscle, but it's all merging into one at this point, because I think the muscle tendon interface is an artificial separation. So we'll see bursitis of psoas, iliotibial tract. They talk about hamstring snapping. I've never seen that. You get anterior snapping from psoas, lateral snapping from the glutes. This is the iliopsoas paratendinitis with fluid tracking around that psoas tendon on the left. Typical appearance. And this is a raging enthesopathy of the hamstring, attachment on the ischial tuberosity. Muscular cause is actually probably the most common injury I see in football. About 45% of all of my referrals are for muscle injury, and they lose loads of time. So they're obsessed with it, but again, this is a whole separate discussion. But we'll just run through just a couple. This is an iliopsoas injury. This is a psoas coming down here. This is a tendon almost certainly injured at its insertion. And this is Obturator externa strain. Footballers actually bizarrely do very well with these. They seem to be able to function at a high level. So in summary, when we're imaging hip and groin pain, we have to consider the different potential pain generators. What we're really interested in this talk, I suppose, is about hip impingement and how we diagnose it on imaging. The first line investigation should always be a plain film. And then after that, it'll be an MRI, and whether you have access or desire to use MRI arthrography, just bear in mind that still is considered gold standard for labral tear detection. So thank you very much for listening.